Welcome to Eye Contact. I'm Rudy Nuijts. I'm speaking with Dr. Mor Dickman about a potential new technique, Scleral Cross-Linking. Welcome, Dr. Dickman. Please tell us about this new procedure, Scleral Cross-Linking. What is that exactly?
Well, we all know that corneal cross-linking revolutionized the treatment of keratoconus. It's been available in Europe for more than 10 years and recently also in the United States. But now people are examining novel applications of this technique, and one of the most exciting ones is the treatment of myopia. We know that myopia is a global epidemic. In some parts of the world, even more than 80% of the people are suffering from short-sightedness of myopia, especially in Asian countries. So we're looking for novel ways to see if we can stop the progression of myopia. But actually, if we look to the history of this treatment, we see that in 2003, the group of Wollensak and colleagues introduced the first paper for corneal cross-linking, and already 2 years later, in 2005, they described the application of riboflavin with ultraviolet light to treat the sclera for scleral cross-linking with the idea as a treatment for myopia. Unfortunately, in the first experiments that they used an irradiance of 4.2 milliwatt per square centimeter, there was extensive damage to the retina due to the toxic effect of UVA light. At the moment, there are many groups, including ours, that are working on novel cross-linking modalities, and those can be divided to chromophore cross-linking, which is similar to riboflavin UVA, whereby a certain compound is used with the use of light creates free radicals that lead to cross-linking of the collagen, and pharmacological techniques that do not require the use of light. Our group is working at the moment together with our group in Maastricht, is working now with Weizmann Institute of Science in Israel, Professor Schertz, that developed a treatment called WST11 or TOCAD, which is a bacteriochlorophyll. It's derived from, it's a synthetic derivative of a pigment used for photosynthesis in plants. And the advantage is that this chromophore can be activated by near-infrared light. And as you know, near-infrared light has very good tissue penetration. So it would enable safe treatment of the sclera through the pupil, the same way that we use a three-mirror glass in order to treat retinal conditions. You can imagine that we can bring near-infrared light through the retina and the choroid to the sclera and stiffen the sclera this way. And this is a very exciting development.
Well, Mor, that's very intriguing, of course, how this is going to work, this new WST in combination with infrared light. But do we know also on a histopathological level and a biomechanical level what actually happens with the sclera? Do we know that?
Yes, well, we know that myopia is characterized by changes to the sclera. So it's very important that we treat that. In the past, there was a big discussion in our community whether the sclera changes were primary or secondary. We now know that in response to defocus of light, which occurs in myopia, a signaling pathway is involved between the retina and the choroid and the sclera. So if we attack the sclera and treat that on time, it is a potentially revolutionary treatment for myopia. But then we need to consider what is the effect that is achieved and what are the safety parameters. In terms of the effect, we know today that scleral cross-linking by a variety of novel modalities, but also using riboflavin and UVA with a lower irradiance of 3 milliwatt per centimeter square, like used for the cornea, can achieve a highly significant stiffening, a highly significant increase in Young modulus of the sclera. And in animal models with myopia, we know it can even arrest axial elongation. It can arrest the growth of the eye. So in terms of effect, I think the results show it is a very promising, effective therapy. In terms of safety, we would ideally like to see no histological changes whatsoever. So for riboflavin and UVA light, as I said, when you decrease the irradiance to lower levels like used for corneal cross-linking, there was a report that there was no damage seen to either photoreceptors or retinal pigment epithelial cells. We also have today pharmacological cross-linkers, like the geniping, which is derived from the Jardinier plant. And the advantage of pharmacological agents is that they do not require light for activation. So we can envision that they can be administered subtenonally, and then you do not require light to achieve stiffening. And they achieve similar effect to the riboflavin UVA, but without ultraviolet A exposure. The disadvantage is that you do not get a localized effect, and you can hamper the growth of the eye, because myopia is a disease of children who still need to grow.
Now, you brought in two important parameters into the discussion, which is safety and efficacy. How will we be able to measure the efficacy of scleral cross-linking in eyes? You know, in corneal cross-linking, we can look at demarcation lines, we can look at the curvature of the cornea later on. How can we measure that it is really effective, do you think?
Well, I think even with corneal cross-linking today, we're not actually measuring the effect of biomechanical stiffening in the eyes of the patient. There are experimental techniques like Brioline microscopy, but we're not measuring the effect. With scleral cross-linking, the effect will be measured by change in refraction and by change in axial length. And in that sense, I think it's very important. One of the big challenges is to identify the children that would most benefit from this treatment, assuming that it is safe. Who are the children? Do we know good enough how to predict which children will be progressive and will require treatment? At which age do we need to treat them? And how much do we need to treat them, which is enough to arrest myopia, but will not cause the eye to arrest its development?
Mm-hmm. And do we have from the lab studies already any ideas what is the relationship between dose and effect now, and how we should, you know, bring that into the clinical situation depending on the level of myopia, for instance?
Well, our group has sent samples treated by WST11 and near-infrared light to Keith Meek's group in Cardiff in the UK. And they've shown, in terms of safety, some very interesting findings that the treatment does not change. It results in a very significant, highly significant increase in the stiffness of the sclera, more than between 100 and 200% increase, which is very much. But they also showed, which is very important, that the fiber diameter and that the distance between the collagen fibers does not change. So with two fluorescence microscopy, photon microscopy, they showed that there is increase in cross-links. So to conclude all these findings together, we can say there is a highly significant increase in scleral stiffness following the treatment. There is no change to the microstructure and architecture of the collagen fibers, and this increase in stiffness is related to a significant increase in cross-linking between the collagen fibers. What is the dose needed to achieve arrest of myopia is currently unknown, so it is important to stress all these treatments are experimental and should not be done on patients at this stage.
One big question, of course, is when can we start clinical trials? When do you foresee that we could start really in patients with introducing this new treatment? Is that in the near future or talking about 5-10 years from now?
Well, I think we have to be very careful with trying these experimental treatments on children, and we've had some unfortunate examples in recent years for treatments that were innovative and very exciting, but were tried upon children and too early stages. I think the major obstacles we need to cross at the moment to reach clinical trials are, first of all, delivery. If we're talking about chromophore cross-linking, whether it's riboflavin UVA or it's WST11 near, we need to know how to deliver the treatment properly, because for riboflavin, if you look at the animal studies, it requires a very extensive exposure of the post-equatorial sclera in order to deliver the treatment. So I think solving the delivery issue is critical in reaching clinical applications. And on the other hand, we need our colleagues to produce predictive models to tell us who are the children that would require this therapy and when they should best be treated. And until that is available, I think clinical trials are not an issue yet.
Well, thank you very much, Mor, for all this interesting information on scleral cross-linking for the treatment of myopia. For more information on this and related topics, please visit us at eurotimes.org. Thank you very much.